pathophysiologic concepts are beautiful as well. So today, I'm hoping you already have in your viewing the little eyeballs my PowerPoint that says myopathies and neuropathies. So just as a final test, I'm going to ask everybody quickly again, can you all hear me and see my PowerPoint myopathy page? And I'm seeing yes, 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 rolling down the line here. So we might as well start. If you think of the last big chapter as being central nervous system, then a good place to put neuropathies and myopathies would be peripheral nervous system, because you can really consider, of course, nerves as being the peripheral nervous system, and the things that is at the end of these nerves that are intimately part of them, the muscles, are part of that as well. But, you know, in a way, we also considered muscles part of soft tissue. So muscle is something that's not easily classified, but there aren't many primary muscle diseases. That makes it nice. So what will we be doing today? What we'll be doing today is the most simplistic thing of all. We'll be talking about 7 common neuropathies. Neuropathy being defined as any primary disease of nerve. And we'll be talking about 9 primary myopathies. And myopathies are defined as any primary disease of muscle. And specifically, I would probably have to say striated muscle. In other words, the muscles that have striations, which include skeletal muscle and cardiac muscle. Generally speaking, myopathies exclude smooth muscle, because smooth muscle is more the domain of soft tissue. So in the first part of the session today, we'll talk about 7 really, really nice, common, hopefully easy to understand neuropathies, following the same pathologic classifications that we've been doing all along, all throughout the year. We'll talk about the prime example of an inflammatory neuropathy, an infectious one, which is an inflammatory with a pathogenic etiology. We'll be talking some of the general classification of the hereditary neuropathies. We'll be talking about acquired, which are the most common. That's why they're in the biggest letter. Of course, diabetes is number 1 on the list, but there's a few others. We'll be talking about the traumatic neuropathies, because if you cut a nerve, you injure it, don't you? And then last but not least, the rather rare but very easy to understand neoplasm. And then in the second half, we'll be talking about the various primary things that can go wrong to muscles. You know, we mentioned denervation as the big thing because it's the most common type of myopathy, but it's not even really a primary myopathy, is it? It's a disease of nerve. We'll be talking about the muscular dystrophies, or Jerry's kids, the so-called neuropathies based on ion channel anomalies or diseases, the general vague category of congenital, or therefore hereditary myopathies, the ones which we consider metabolic, the inflammatory ones, the toxic ones, and then the ones that occur primarily at the neuromuscular junction, and then finally, as always, last but not least, the neoplasms. The thing that is always used to describe nerve tissue histologically is the word wavy, W-A-V-Y. Because for some reason, when you cut a nerve, especially longitudinally, but even obliquely, you'll see 2 things. You'll see nuclei, and then you'll see kind of a whitish, slightly washed out material, which you should know is myelin. Every nuclei that you see within a nerve is of a Schwann cell. Oh, I'll admit there might be a couple of fibroblasts every now and then if it's a big nerve and it has some little fibrous bundles between it. But you could think of a nerve as nothing, like a telephone cable. In other words, you have the actual wires, which are the axons, or if you want to call them nerve processes, and you have the insulation surrounding the wires, which is the myelin. And there may be some wires in there that are non-myelinated or non-insulated too. But the nuclei, every nucleus you see in a nerve is of a Schwann cell, which are the cells that are making the myelin. So it's easy to understand then, if the only cell nucleus inside of a nerve is a Schwann cell, the only tumor you could theoretically have of a nerve would be a schwannoma. Maybe some fibromas too, but they're very, very, very rare. Here is that same exact structure now cut longitudinally rather than transversely. And you'll see little dots surrounded by lighter fatty areas. Well, these little dots are your actual axons, aren't they? These are the nerve processes. And the whiter area around them is the myelin sheath. And you can see that some of these little axons have a lot of myelin, some have very, very little, and some have none if you look somewhere, which means something that you already know, that many, if not most, nerves are mixed with both myelinated and unmyelinated fibers. Another name for an axon would be a fiber. This is a regular H&E stain, hematoxylin and eosin. Looks kind of nice, doesn't it? This is that same nerve now with a stain, a silver type of stain. If you remember, Dr. Ramon E. Cajal got a Nobel Prize for figuring out how to stain axons or nerve fibers. And this is a modification of his Nobel Prize winning work in which you could see now the axons or the fibers are stained very, very black because the stain, the silver stain, goes to the axon. And then surrounding it, like you would expect, is a washed out area of the myelin. And remember, myelin, if you remember from your biochemistry, is largely fat. So what does fat do on usual preparations when you pass it through the xylene? It washes out. So in the silver stain of a nerve, you have a black axon surrounded by white, washed out, fatty myelin. If you took a myelin stain now, you see the myelin stains intensely black. This could very easily be one of the fatty or myelin dyes like osmic acid, but there's a few other ones, oil, red oil. Any of the fat stains theoretically should stain myelin pretty well. Osmic acid stains it great. But now you don't see any axons at all, and you only see the myelin. So it's almost like this picture is a negative of this one, and it really is, because up here you see a lot great axons and no myelin, and up here you see great myelin and no axons. But in all practicality, when you're examining tissue, when we go through your lab cases, nerves are going to look boringly simple. They're going to look like they have a little fibrous capsule around them. You're going to see all these nuclei are Schwann cells, and then you're going to see some sort of feathery type of cells. And if the nerve is cut transversely, it'll look like this. You'll see these little tiny dots surrounded by clear zones. And if the nerve is cut transversely, it'll have more of a wavy component to it. So here's a nerve, here's a nerve, here's a tiny nerve with only what, maybe 7 or 8 axons. Here's fat tissue. Here's a little loose connective tissue. Here's part of a blood vessel, probably an artery. Here's a vein. So all your classical soft tissue elements are in this one little picture here. Here's another picture of a nerve, and it's taken from your histology series. So like if I was to ask you how many axons are in this nerve, you could probably figure it out by just counting them. I would say as a quick estimate, there's around 20. If you think there's 15 or 30, I'm not going to fight with you. It looks like it's about 20 to me. And you can also see that the nuclei have to be nuclei of Schwann cells. And any little body that you see surrounded by a halo is probably an actual axon. Okay, here's another neurovascular bundle. The thick artery, the thin vein filled with blood, and the little nerve. And in this case, it looks like there's maybe 12 or so fibers within that nerve. You know, in every nerve of the body, even the optic nerve, we know exactly the number of axons. For example, it's amazing some of the research that's done. You could probably go to an ophthalmologist and say, you know, how many axons are in the optic nerve, and he probably know the exact number. It's a very definite number, like maybe like 100,000 or something like that. Here is another nerve here. Can you see? It's very small. Maybe there's only about 5 or 6 axons. You can see 1 or 2 Schwann cells. You can see some skeletal muscle up here. You can see a big, thin-walled vein dilated with blood over here. You can see an arteriole over here, thicker walled. And you can see loose connective tissue just about everywhere else, and maybe even a little bit of fat. So this is your classical, nice histologic prep of connective tissue, which includes skeletal muscle, nerve, and vein, artery, fat. Here is another picture of a nerve. Do you notice in this picture there's a little more waviness to it? And plus, it doesn't look round, does it? It looks more oblong. So the more oblong or longitudinal or hot dog-ish a nerve will look like, means it'll look a little more wavy too, because when you cut a nerve longitudinally, it looks very wavy. Here's the electron microscope. Don't be freaked out by it. But in electron microscope preparation, the myelin is stained very, very black. So when you cut through a nerve and you see these real thick, black, dark, osmic acid preparations of the nerve, 1, 2, there's about 6 or 7 here. You know that these are myelinated nerve fibers. You can also see that in this nerve, there's a lot of unmyelinated nerve fibers. In fact, there's more unmyelinated than there are myelinated. And of course, when you look at something like this, or this, or this, or this, or this, you know these are probably Schwann cells. Actually, I know they're Schwann cells because they have a big S on them. And I think when you see something that is more spindly like this, this has a F. So I told you sometimes you have an occasional fibroblast. So when I told you all the nucleated structures in a nerve are Schwann cells, I lied a little bit. There's an occasional fibroblast. But look, isn't this a beautiful Schwann cell? You can see it's right in proximity of a something that has laid a nice coat of dense myelin around the nerve. Here's another picture of a nerve. And don't forget, in the actual axons, you have both neurofilaments as well as microtubules. If you kind of remember that from your basic neurobiology, the neurofilaments are nothing but tiny dots, even on the highest preparations. And of course, the microtubules, if you remember, have that classical 9 and 2 preparation, you know, like a cilium or a sperm tail. So they look like rounder bodies. So here's a microtubule here, one over here, maybe one over here. But these little dots, and they're really seen the nicest here, are you actual microfilaments. Here's one that shows a really high power view showing how nicely the myelin wraps around the axon. And then in the axon, you can see both 1, 2, 3, 4, 5, maybe about 8 or 9 microtubules. And then these tiny dense dots are the microfilaments. Another thing that you could do is actually measure them. So if you wanted to have a trivia question with your friends, and you could say, how many layers of myelin are in 1 millimicron, or 1 micron, if you remember, is if a red blood cell is 7 microns, 1 micron would be 1/7 of a blood cell. And if you could actually count the layers here very nicely, and according to my general estimation, it takes, because there's about 30 layers here, and it's half of a millimicron, or micrometer, if you will, or micron, you could probably guess that about 1 micron is 60 layers of myelin. So this is like about 30 layers, and this is a typical number of layers for the myelin sheath of a nerve. Okay, I'm very happy with nerve. Muscle is even easier. The general rule is skeletal muscle has striations. If you cut it longitudinally, it looks like logs. There's no interconnections between the logs like you see with the cardiac muscle fibers. And the nuclei are at the periphery of the fiber. And a skeletal muscle cell is a skeletal muscle fiber. Now, sometimes when you cut it longitudinally, you can't appreciate the fact that these nuclei are on the edge because some of them might be cut tangentially. But when you take that same thing, where you can see the striations really nicely, and then you cut that same thing longitudinally, you can't see the striations anymore, can you? But you can see the fact that the nuclei are at the very, very periphery of the fiber. And even though you can't see striations, you know this is striated skeletal muscle. Here's another electron microscope, and I don't want to go over all the physiology and everything, but I have always thought of the contractile unit of a skeletal muscle as being like the United States of America, because it goes from Z to shining Z. And if you remember, the general progression is Z-I-A-H-A, and if you actually wanted to coordinate that with what each zone represents, the Z bands are the ends of the unit from which both the actin and myosin connect. The actin are the thinner fibers, which have an interruption in the middle called the H band. The myosin is very thick in that center portion, but very thin towards the end. And as you know, the general rule is in the contracted state for the actin to slide closer to each other. And if you wanted to really be a jockey and you want to look at the actual components of the muscle, you could see that these are the various troponin components and light chains and so forth. And that's really kind of a neat thing to do. Here's another electron microscope of a muscle, and this one is cut longitudinally. And these real thick dots here are the myosin, and the very tiny, almost ones that you can barely see are the actin. And you can see that these little vesicles here, if this was a cell, you would call a series of vesicles a endoplasmic reticulum. But because it's a muscle cell, you call the same thing a sarcoplasmic reticulum. I think you could recognize these mitochondria very, very nicely as well. And the one thing, and here's another mitochondria, and here's probably one as well. The one thing I wish I could have shown you better were some of the glycogen granules. And here's some glycogen granules over here. You see these dense, tiny things. This is these are your little food cells for the whole process. So we have, I think, pretty well reviewed the general histology of both muscle and nerve. I hope we have a good picture of it, because now we're going to be talking about situations that alter this beautiful anatomy and alter this beautiful histology and physiology. So let's do nerve, then we'll take a break, and then we'll do muscle. But before we do them individually, I want to go all the way back to chapter 1. Do you remember in chapter 1, we talked about things that cells do when they're injured, when they're dead, when they're dying, when they're reversibly injured, when they're irreversibly injured? Well, there's no exception with nerve and muscle cells. So I want to emphasize to you that no matter what specific disease we're going to be talking about today, we're going to be talking about processes that are non-specific and may occur very notably in a variety of neuropathies and myopathies. For example, demyelinization. That's one of the most non-specific degenerative reactions of a nerve, no matter what the disease is, no matter what the etiology is. Axonal degeneration, or degeneration of the axons, or the things inside the myelin, that's also non-specific. And the general rule is if you disrupt it, it dies, especially distal to where the nucleus is. You also know that it can regenerate as well under certain circumstances. So in the muscle fibers, we talk about the classical changes of necrosis. We could see muscle fibers or muscle cells undergo vacuolization as well. Remember, we told you that one of the nonspecific changes in any cell that's injured could be vacuolization, necrosis. In muscle fibers, we can also see regeneration as well, just like we see with nerve. Generally speaking, though, I want to remind you of one thing. The two cells that we're talking about today, nerve cells and muscle cells, if you remember from your general histology, they don't divide, do they? They don't undergo mitoses. There's no spindle apparatus in the normal neuron cell or skeletal muscle cell. So when we talk about regeneration in these things, we're generally talking about regeneration of cytoplasmic or non-nuclear elements, because I want to emphasize with you, we're talking about two systems today in which these cells do not multiply. Another thing that's really, really interesting with muscle fibers is that if certain muscle fibers are injured and they're atrophic or small or they don't work or they're degenerated, there's a process by which the non-injured fibers get bigger. So there's a constant homeostasis between fiber atrophy and fiber hypertrophy. And sometimes, like if you're Samir and you're lifting weights, then yeah, your muscle fibers are going to be really thick. But let's say you're not Samir and you're not lifting weights and you have a myopathy and some of those fibers are atrophic. Well, then in order to do the same amount of work that you would normally have to do with those muscles, like walk, for example, the non-sick fibers, the healthy fibers, hypertrophy. So sometimes hypertrophy is a sign that some of the other fibers are dying. Okay, this is a nice general schematic. I think it might be from Robbins. Here's your normal motor unit. Here's your neuron. And remember, the nerve itself does not have the nucleus of the neuron. It only has the axon. The only nucleus in the nerve are these Schwann cells, okay? In a segmental demyelinization, you have occasional dropout of the Schwann cells. So you have part of the wire that's insulated here, and then there's a missing area, and then it's insulated. So this is segmental, don't you? Another general non-specific process, which we mentioned, was axonal degeneration. So think about it. If you cut an axon right there with a butter knife, what part is going to die? First, and more readily, and more certainly, the part that's away from the nucleus, or the part that's closer to the perikaryon or body of the neuron. Of course, it would be logical that the part that would die first would be a part that's away from the nucleus, because this area can always grow back, and sometimes it does. And even if it does grow back, and even if it regenerates, remember, that nucleus there is not dividing, is it? So you can have reinnervation. If this thing grows back, it could then go and reinnervate the muscle cells. In a primary myopathy, however, the nerves may be beautiful and myelinated and not degenerated and myelinated very well, but there's a primary process going on with the actual skeletal muscle fibers themselves. Or actually, I should probably say striated muscles, because a lot of the myopathies that we'll be talking about after break also involve the striated cardiac muscle as well. So, what's the best example of demyelinization? The best example is the mother of all demyelinating diseases, or multiple sclerosis. And here we have nerves that are not in the peripheral nervous system, but they're tracts in the central nervous system. You could recognize this as spinal cord. And if myelin is a fatty substance, and we stain the myelin with a fatty stain, which makes it look black, if you have an area that is not stained, that means there's no myelin. So this is a classical example of an area of demyelinization. Now, let's look at another nonspecific finding of muscle. Does the muscle fiber, does the muscle cell look redder and denser and non-uniform and loss of striations? That's muscle fiber necrosis. Remember when we saw the cardiac muscle fibers with a myocardial infarction. We said one of the first things to happen is for the nucleus to dissolve. Remember, we call that karyolysis, karyorexis. Well, look, the nuclei along here are gone. But the nuclei along these normal fibers, where you can still see some remnants of striations, by the way, if you look very closely, I could definitely see some little striations here. If the cell is healthy enough to have striations, it's probably healthy enough to have peripheral nuclei. By the way, just offhand, I'm very curious. I'm going to have to ask for a quick vote here. Can you actually see the little striations right up here? If you do, then that means that your images are as good as mine. And let's see what we're seeing. Yeah, I'm seeing a lot of people say, yeah, that means you have incredibly good pictures. Now, I guarantee you, if you were sitting in a classroom, even the people in the middle of the room would never be able to see these striations. But because they're right in front of you, just like they're right in front of me, you can see things much better now. That's so important for pathology. Here's another non-specific finding of necrosis or damage, perhaps reversible, perhaps irreversible, in a muscle fiber, and that's vacuolization. You see these vacuoles here? Here's one here, here's one here, especially this one here. Look, you have a vacuole here, which is definitely within the fiber, don't you? In this high power view, you see not only is this particular fiber here smaller than normal, or in other words, atrophic, but there's some vacuolization going on in it as well, can't you? And of course, you would not expect to see striations even if the surrounding fibers were healthy, because this is a axial cut. If you are looking at healthy fibers that are cut longitudinally, you can usually see striations unless your histologist does a shitty slide. Here's one of the most common things to see in just about any type of myopathy. And look at this. Do you remember when I showed you all of those normal pictures of skeletal muscle? Do you remember that generally all of the logs were approximately the same thickness? Well, look, here's a thin log, here's a thin log, here's a thin log, here's a fat log, here's a fat log. What does that mean? It means that within this section of muscle tissue, some of the individual fibers or cells, you know, a skeletal muscle fiber is a skeletal muscle cell, are atrophic, and the adjacent relatively healthier ones get bigger and become hypertrophic. And they get bigger without even lifting weights. They just get bigger because they have to do the same amount of work, but some of these fibers here are just too small to do it. And in addition, you can see some inflammatory cells as well. You can see a nice big arterial blood vessel here. You can see a vein over here. And either this is a vein here or fat, and that's probably an arteriole over there. And here's just another layer of fibrous tissue between muscle fascicles. Yeah, and you see Samara's big muscle there? That means in his muscle, all of the fibers are hypertrophic. Okay, now we have talked about nonspecific general changes in nerves and muscles due to any type of disease. Now we're finally going to talk about specific diseases. And I told you we're going to talk about 7 primary neuropathies, all of which are common, most of which you may see somewhere in your life, and we're going to talk about 9 myopathies. That's a nice general number. And some of these myopathies are general categories. For example, I might talk about a genetic metabolic myopathy, but I may show you that there's a chart showing that there's 500 different ones in which they've worked out the genetics already. But let's get going. The classical inflammatory type of neuropathy is Guillain-Barré syndrome. Guillain-Barré syndrome is still an obscure disease. We don't know what causes it. Nothing can be cultured from it. So whenever you have a disease that's inflammatory, and it's not clear if there's a specific pathologic agent, it generally gets dumped into the category of autoimmune, because if the agent is not coming from outside the body, then it must be coming from the inside of the body. So what is Guillain-Barré? It's an autoimmune, or at least unknown etiology, inflammation of a peripheral nerve. And remember, one of the things we said is that whenever anything damages a nerve, whether it's an axe or a gunshot or a knife or a virus or bacteria or an antibody against your own myelin, which is the most probable process going on in Guillain-Barré, it's going to result in demyelinization. So if you can remember Guillain-Barré as an inflammatory neuropathy that is probably autoimmune because we can identify antibodies against the patient's own myelin gangliosides, then that's how you think of the neuropathy. And if it's causing that myelin to be damaged, then it's going to be demyelinating. And clinically, it is an ascending paralysis from the patient. In other words, it'll start more peripherally in the extremities, and then if the disease or when the disease progresses, the paralysis will get more close to the central torso and centrally located muscles. So here's a picture, and really, what can you really say about this? Well, let's say that you can recognize this little rod here as being an axon, and let's say that you could recognize the lighter zone around it as being the myelin, so you know this nerve is being cut longitudinally rather than transversely. And really, all you can really say is that there's a lot of inflammatory cells within this nerve. And that's the tip-off, because remember, I told you the only nucleated cell in a nerve should be a Schwann cell, but look, you have your typical inflammatory infiltrate. It looks like they are primarily lymphocytes, but I think there's some neutrophils here. I think that there's some macrophages. I think this might even be an eosinophil, even though I will not necessarily agree that these are all overwhelmingly neutrophils. The other appropriate name for Guillain-Barré is acute inflammatory demyelinating polyneuropathy. So by polyneuropathy, you absolutely know that it usually involves more than one nerve, doesn't it? Another way to think of an inflammatory condition of peripheral nerves is being inflamed due to specific pathologic agents. For example, a bacteria called leprosy, or a toxin of another bacteria called diphtheria, or a virus called varicella zoster, the mother of all neurotropic viruses. So if you want to remember that leprosy, diphtheria are specific pathogens, that two of which can be cultured, that infect nerve and show inflammatory changes, you can remember it. You can also remember, if you've seen some of these hideous pictures of people with leprosy, in kind of like an auto amputation, not only do they have these little nodular areas, perhaps either mildly or severely, but in a lot of cases there's auto amputation. There's auto amputation because there's no nerves feeding areas, and therefore the whole part of the soft tissue or of an extremity might eventually, auto amputate. And remember, we said that leprosy is a acid-fast bacteria like TB, and therefore it's probably, look, if you do a stain like these little red bars here. Otherwise, all you see here is a nerve that is infiltrated by inflammatory cells. Okay? Here's a high-power view of the Clostridium diphtheriae bacteria. It's not so much the bacteria that's causing the neurotoxic damage, but it's a neurotoxin of the bacteria. Maybe in about 10 or 20% of the cases, there's significant neuropathy with diphtheria, which is otherwise a just very, very, very whopping upper respiratory tract infection, especially of the trachea and bronchi, the so-called pseudomembranous fibrinous changes. I don't know if you've ever had zoster before. It's caused by the same virus that causes chicken pox. It generally distributes itself along a dermatome because the zosters love to live in the dorsal root ganglia, and they travel down the nerves. And eventually, every now and then, for some unknown reason, they cause these little vesicular rashes. And usually right before the appearance of this, and overlapping into the appearance of these vesicles. Remember, herpes means snake-like crawling vesicles. There's an extreme neuralgia, and I don't know if you've ever had zoster before. It's really, really painful. It can occasionally mimic a kidney stone or a myocardial infarction. Very, very painful. Let's talk about the hereditary neuropathies now. These are getting more and more complicated every year. The hereditary neuropathies, because they involve both motor and sensory nerves, have an acronym called HMSN for hereditary motor and sensory neuropathy. The original one was also called Charcot-Marie-Tooth. But as time goes on and we get more into the understanding and classification of diseases, the classical Charcot-Marie-Tooth was only HMSN1. There's also another variant called HMSN2, and it's similar to HMSN1, but involves more the neurons, myelinization closer to the neuron than the HMSN2. In addition, as you might guess, there's an HMSN3, and it generally results in changes in which it thickens the nerves and shows some fibrous reaction to them. And in some cases, in HMSN3, you can actually palpate these nerves, little nodules. And to make matters even worse, if you want to remember that HMSN3 is called Desjardins-Sotas, just like HMSN is called Charcot, you can, except I would think it would be really sadistic if somebody ever expected you to remember that. The one thing that you should remember in terms of classical things is the so-called pes cavum, or the cave-like arching of the foot, which you see in HMSN1, which is Charcot-Marie-Tooth. So because I used to give this lecture to the podiatrists, I would always show them the classical pes cavum. Of course, they already knew that a lot better than I did. Also in Charcot-Marie-Tooth, which is HMSN1, you can have perineal muscle atrophy as well. But the classical pes cavum, if you want to remember, it's a cave-like hyperarching of the foot, is a classical finding for Charcot-Marie-Tooth, which is your hereditary neuropathy. Okay, we've been talking about things which so far are relatively rare, but probably in your practice, your regular clinical practice, when you see a patient with a neuropathy, you're going to be asking yourself questions like, well, is the neuropathy only in one nerve or multiple nerves? Or does it seem to be symmetrical in distribution? Does it involve primarily sensory function or also motor function? And of course, if it involves motor function and it's severe, there'll be motor fiber atrophy. Because remember, the rule is if you cut the nerve, the muscle fiber dies. And you might also ask whether the changes are somatic or autoimmune. So, in the so-called general toxic metabolic one, they're generally symmetric and multifocal and involve all kinds of nerves, both sensory and motor. What are the two common biggest causes of general toxic metabolic neuropathies? Well, diabetes and chemotherapy. My wife had a very, very whopping neuropathy on the basis of some of her chemo that she received at the University of Chicago. And diabetes probably there's probably more, if you treat 10 neuropathies in 10 years or 1 year, depending on what you're doing, probably 8 of them will be from diabetes. But remember, certain vitamin deficiencies, like many of the B vitamins, even vitamin E, can cause some of the toxic materials, like organic compounds, insecticides, heavy metals. These are also regarded as being relatively toxic to nerves as well. Do you remember the diabetic foot ulcers? Do you think that the ulcers are there simply because the distal extremity is having ischemia? Well, that's only part of the answer. I think the thinking is that if you have a diabetic with a foot ulcer, they have more than just a little bit of ischemia. Whenever you have a diabetic with a foot ulcer, chances are there's a significant neuropathy going on as well. Because remember we said when the nerve doesn't work, the soft tissue degenerates, and certainly the muscles die as well. And in the actual neuropathy of diabetes, we have 2 things going on. You have a direct toxic effect due to the abnormal blood chemistry, and you also have some demyelinization going on as well. So the neuropathy with diabetes is both a demyelinization, nonspecific process as well as a toxic process. Now, I know what you're thinking. You're thinking, well, could a toxic process cause demyelinization or demyelination? And the answer is yes. So maybe it's really only one thing rather than 2. Okay, let's talk about a traumatic neuropathy. Think about it. You cut a nerve, it dies. Maybe it'll regenerate. If it does, it's going to regenerate very, very slowly, perhaps like a millimeter a week. It's generally a very slow process, but that's assuming that the ends are pretty close in line and there's been no secondary other trauma or hemorrhage or inflammation in the area either. If you avulsed a nerve, would it cause a neuropathy? Of course, because that's a traumatic change. If you compress a nerve, like a median nerve, due to a carpal tunnel syndrome, would that cause a neuropathy to the areas of median nerve that supplies? Of course it was. Very frequently, when a part of an extremity has been amputated, especially a lower extremity, which are most of the lower, you have an overgrowth of nerve tissue, which is called a neuroma. It's not really a true neoplasm, but it's generally an overgrowth of the nerve, and especially the fibrous tissue that surrounds the nerve. You know, there's something called Saturday night palsy that may have been explained to you in anatomy, but it generally means if you're falling asleep in a weird area, like you got drunk on a Saturday night, and you're generally falling asleep in a chair, and perhaps one of your axillary nerves is being pressed against part of that chair, you know, you're going to have a palsy there. And last but not least, there's probably more of a true neoplastic condition called a Morton's neuroma. It's not really a true neoplasm. It's still mostly just an overgrowth, but that has a classical finding as well. So let's look at some of them. Here's a traumatic neuroma, and it doesn't really look like a neoplasm, does it? It looks like a bunch of nerves in which are kind of twisted and growing in all general directions, not really look like they're going anywhere, but look at all the fibrous tissue between them. So the traumatic neuroma is more of a reactive condition of the fibrous tissue rather than a true neoplasm of the nerve. And of course, you know that you really can't have a true neoplasm of a peripheral nerve because a peripheral nerve doesn't even have a nucleus. Okay? Here's a Morton's neuroma. And if you want to remember this, I know this was very important for the podiatry students. Everybody knows that a Morton's neuroma is basically a bump, a very subtle bump on the sole of a foot. But if you want to know classically what a Morton's neuroma is, and if you remember that you have both a medial and lateral plantar nerve, and the medial plantar nerve has a medial branch and then 3 common digital branches. Well, a Morton's neuroma is a thickening. It's a fibrous overgrowth of the 3rd common digital branch of the medial plantar nerve. Very often it's caused by trauma, like a traumatic compression like we saw with the amputation neuromas. They're, for some reason, more common in women than in men. And if you want to see what one looks like, you may miss it because sometimes they're very subtle. It could just be about sort of a subtle little bump like you see here. And in here, you could see it even more subtly. There's nothing here, but you could tell that there's something here. Okay, so that's your Morton's neuroma. Okay, last but not least, it's almost break time. We'll deal with the last topic. Is there such a thing as a neoplastic neuropathy? Yes. And remember we said the only kind of cell in a nerve was a Schwann cell? So if there was a proliferation, a clonal neoplastic proliferation of the Schwann cell, that would really be like the only real primary tumor of a nerve. You call it a schwannoma. If it was a malignant proliferation, a sarcomatous proliferation, in which there's both invasion and potential metastases, you call it a malignant schwannoma. At any rate, 90% of all the schwannomas are benign. I don't think I've seen too many malignant ones. And it would look perhaps like a bump, like another soft tissue swelling. And of course, just because it looks like this, that doesn't mean it's a schwannoma. You would, if you could dissect through that and see that it's actually originating from a nerve in that area, you could. But most likely, because that's so much bigger than any possible nerve in that area, just from the examination of the patient, I could really call that as a bump, perhaps a soft tissue bump. So histologically, I want you to remember the word palisading. Remember we used the word palisading when we're talking about basal cell carcinomas. Remember we used the word palisading when we talked about rheumatoid nodules where the fibroblasts palisade at the periphery of the fibrous nodule. Well, look, there's palisading here too. You see how these things are kind of like in a row? So one of the features of schwannomas, usually, always, is that there's an area in which you see palisading. And the palisaded area is called Antony A. And then invariably, there are generally the same types of cells, but they're generally more unpalisaded, unorganized, might be very, very edematous as well. And that's called Antony B. So what do you remember from this? Antony A in a schwannoma is a palisaded area. Antony B is a non-palisaded area. Last question before break, and I think we've already gave you the answer 3 or 4 times. Why are schwannomas the only real tumors of a peripheral nerve? Well, the answer is because Schwann cells are the only cells in a peripheral nerve that have nuclei. Okay, let's take a break. You know, I think we're going to finish at a reasonable time. Who wants to be the bad guy? Isla, do you want to be the bad guy? Why don't you play 2 or 3 songs and then tell us when we have to come back in about 10 minutes, okay? But before you do, I'm feeling a little bit taken on Margaret's job to be the party pooper, but that's okay. Folks, I feel really, really, really good. Why? Because often we feel good when we could see the light at the end of the tunnel. Now, it's not like I haven't had fun, and hopefully you haven't had fun, but like I could see right now that I have only 9 more easy, logical, fun, graphic topics to talk about a little bit. And then we will spend at least a whole week before we go to the island talking about the most beautiful, logical, and in my opinion, simplest concepts of all in central nervous system pathology. And the paradox is, even though everybody would lead you to believe that the central nervous system is the most complex system in terms of diseases, it's the most logical and the easiest. And then we go to the island, and then I get my kid to do the last chapter. I make my son work for a change, even though he's out doing a lot of work, taking care of cataracts and retinas all day. He's going to actually do the last chapter. So in my opinion, I'm already gone, okay? So it's still relatively early. We're going to talk about 9 primary myopathies, and then we're going to call it a day, and we'll call it a week. And might as well start right now. in review, you could probably think of myopathies as occurring due to 9 different types of general categories. And it's really funny because the first category is kind of a paradox, because we said that a myopathy is a primary disease of a muscle. But the fact is, denervation myopathies are really not primary muscle diseases, aren't you? They're diseases of nerves, because the general principle is you zap the nerve, you kill the muscle. We're going to talk about the general things that Jerry Lewis talks about every Labor Day. We're going to look about myopathies in terms of its ability to let potassium in or out of the cell, the so-called channel myopathies. We're going to talk about the general but numerous types of congenital floppy baby myopathies. We'll talk about some general genetic metabolic things. There's a whole bunch of those, as well as our usual thing, toxic, inflammatory. Talk about the neuromuscular junction disorders, of which the absolute mother of all the neuromuscular disorders is myasthenia gravis. And last but not least, we'll talk about some things that are so rare you'll probably never see them in your life. Primary skeletal muscle neoplasms. And I know what you're thinking. You're thinking, well, if Dr. Minarsik just told us that skeletal muscle cells don't multiply, how can you have a neoplasm, stupid? Well, the answer is that the neoplasms of the skeletal muscle are not from mature cells. They're generally from precursor cells. Okay, so here's the number one principle for the most common type of myopathy. You cut a fiber, you injure a nerve fiber, you destroy a nerve, you destroy a neuron, you destroy anything which nurtures that neuron or the nerve, and you're going to denervate the muscle, and therefore it's going to die. So if you want to think of a muscle fiber as being the viable end of a nerve after the synapse, you can. So any disease that you have to that peripheral nerve, or even the anterior or ventral horn cell, for example, like poliomyelitis, you're going to wind up having problems with that muscle as well. This is a classical pattern I want you to remember. I know you're thinking, why are some of these fibers really big and fat, you know, like Samir's biceps? And why are some of them so tiny? They look like very tiny. Well, this is the classical thing. It's the hypertrophy-atrophy scenario. The rule is when you injure certain muscle fibers, the other ones hypertrophy because they have to do the same type of job. Now, if everything was hypertrophied, you're assuming that that muscle is doing extra work, like in hypertension, remember? Or maybe they're lifting weights. Or maybe they're just really strong. Maybe they're working out like Samir. Let's look at spinal muscular atrophy. And remember, we're calling this a myopathy, but it's really a disease of a nerve. And it's a very specific disease. We know that chromosome number 5 harbors the survival motor neuron gene, or SMN1. And when there's a mutation in that from chromosome 5, it affects the anterior horn cells. And if you remember, the anterior horn neurons, if you want to call them the ventral horn as well, you can. They call them by either one, will involve in the atrophy of the muscles that those anterior horn cells supply. And it's often hand fascicular, which means many or all of the fascicles of muscles. Now, clinically, usually the disease involves the muscles that are involved in the shoulder and the hip girdle and the muscles surrounding the humerus and the femur. And that's generally what happens because it's a congenital disease. It's basically in babies. Here's poster child Madison Reed. Don't ask me what year. In the next year, Devon Stantz was the poster child. Beautiful babies. But because They have anterior cell damage due to that specific chromosome 3 gene mutation. You could see that the muscles here, even though a few of the fibers are hypertrophic, most of them are atrophic and degenerated. Also notice, these are not inflammatory cells. These are just the normal nuclei and fibroblasts surrounding it. This is not an inflammatory disease. This is atrophy, remember? SMA, spinal muscular atrophy. There is a general broad term of primary myopathies known as the muscular dystrophies. If you remember, Jerry Lewis has been the MDA poster child for many, many, many years. And the most common types, the classical types of muscular dystrophy are in males because they're both X-linked or sex-linked. They follow sex-linked pedigree. Boys only, women can only be carriers, you remember? And there's two forms. The more severe form and the more common form is known by the name Duchenne muscular dystrophy, also abbreviated as DMD. There's a less severe form, but it's also sex-linked, and it's called Becker's. And I don't know if you've seen any of these telethons, but they show pictures of these babies, and they have a lot of problems. They're generally smaller. They're kids. The one thing that's very, very common is myotonia. And myotonia means increased muscle tone. The muscles are spastic. They have increased rigidity to them. Now, in the next picture, I'm going to show you precisely what the problem is in the most common form of muscular dystrophy, or Duchenne's muscular dystrophy. Here's the problem right here. This is a picture of normal skeletal muscle on the left. And do you see that every one of these fibers looks like it's stained a little bit? The reason why it looks like the membranes surrounding the muscle fiber are stained is because they were stained with an antibody that couples to the protein called dystrophin. Now, dystrophin is a protein in normal skeletal muscle that is an important interface between the muscle fiber and the membrane to which it is that surrounds it. It's a connecting protein. Okay, if you want to know exactly what it looks like, here it is over here. Jerry's kids don't have dystrophin. People with muscular dystrophy, or Duchenne's classically, if you look at the picture now on the right, you don't see that nice little surrounding skeleton surrounding the fibers. Why? Because there's no dystrophin. So the precise defect in the most common type of muscular dystrophy, Duchenne's, is that there's a genetic anomaly that's sex-linked, which they lack the protein dystrophin. You know, this could be a very severe disease. These kids don't always live very long. Of course, it's all boys. And I want to show you in a more routine sort of a way what this picture might look like. And remember, we've seen this picture before. Under H&E here now, we can't really see whether there's dystrophin or not because it's just a regular hematoxylin and eosin. But you can do see that many of these fibers are now atrophic because there's been extensive damage to this muscle. Perhaps there's been some secondary inflammatory changes, and some of the muscle fibers are hypertrophic to compensate. But remember, that's a non-specific finding. Okay, now, perhaps this is a better type of stain for you to see the non-specific hypertrophy/atrophy scenario. No matter what type of primary or even neuro problem there is in the muscle, when you have dropout of fibers, the fibers atrophy, they don't work, they become atrophic, they become smaller. but their friends try to help them out by becoming bigger. So this is probably the best picture I could ever find in all of Google imaging to show you the classical hypertrophy, atrophy type scenario. And I also don't want to lead you to think that, Jerry's kids is only either DMD or BMD. Actually, there's a massive family of so-called muscular dystrophies. They're also called limb-girdle muscular dystrophies. And in most cases, the genetics has been worked out. They know whether it's autosomal dominant, autosomal recessive. We saw in the case of Becker's and Duchenne's that they were sex-linked. They know what the precise locus would be. We know what chromosome it's on. We know what protein is defective, because we know what the gene is that's defective in making the protein. And of course, they all have slightly different clinical pathologic features as well, in terms of what muscles are involved and, what the age of onset is. And I don't expect you to remember all these, mostly because I don't even think it's bother learning myself. There's just a big list. But what's important to remember is that, the so-called Jerry's kids are not just the DMDs, but it's the single biggest group. Okay, let's look into another category of muscle diseases called the so-called channelopathies. And I went to Wikipedia because they have a great concept of an ion channel. And here's an ion channel within a membrane. Here's your classical bilipid membrane, cell membrane. And the ion channel is something that regulates the influx or outgo of ions. In this case, it's potassium ion channel. So, what is the unifying feature between all of the so-called ion channel myopathies? Unifying feature is that there's something wrong with the ion channel, and it could be a variety of things. In many cases, the genetics have been worked out. In many cases, they're hypotonic. In many cases, they're hypertonic. In some cases, they're triggered by things like exercise, cold, or whether there's been a recent carb intake. But if you want to get into the more logical classifications of the ion channel myopathies, they're generally divided into three groups, and that's on the basis of whether the patients have normal serum potassium or too much potassium has leaked out of the ion channel, or too much potassium has gone in and can't leave the ion channel. So those are the basic three classifications of the ion channel myopathies as to whether they're normal kalemic, hyperkalemic, or hypokalemic, respectively. And the one person that's always aware of the ion channel myopathies, even though they're not that common, are the anesthesiologists, because they generally know and they're afraid that sometimes halogenetic anesthetics can trigger this off too and result in a extreme myotonic, hypotonic acute episode, especially in an important muscle like the diaphragm. Another broad classification of myopathies, another really broad classification, I'm not going to bother you with all the details, are the so-called floppy babies. When you get into pediatrics, you might hear the nurse say, oh, we have a floppy baby. A floppy baby is basically a baby that has hypotonia, because the majority of the congenital myopathies, and by congenital, I mean they're born with it, and they're born with it because they have a faulty gene, and there's all kinds of crazy faulty genes involved. But the most common presentation of a baby that's born with a congenital myopathy is that they have hypotonia, or they're floppy. Okay? Let's take a look at a general category of myopathy. And these are also genetic, metabolic. And the one thing about all of the so-called metabolic myopathies is they generally involved the main metabolic powerhouses of the skeletal muscle, which are the mitochondria. So in the lipid metabolic myopathies, there's usually a defective gene which results in accumulation of lipid because of the absence of various enzymes. So that's one type. And in it, you'll see If you do a stain, there's a lot more fat inside this muscle than there should be. If it's a regular H&E stain, it'll look like there's large areas that's washed out. And if you do a fat stain, which stains the fat, it'll look like there's a lot of darker fat accumulating. Another type of metabolic myopathy is your so-called mitochondrial myopathy. And I like this one the best of all because when you look at the mitochondria in this under electron microscopy, it looks like an overcrowded parking lot, and that's why it's given the name parking lot mitochondria. So we're going to look at two pictures. The first one's going to be the lipid, and the second one's going to be the mitochondrial. And remember, they're both metabolic myopathies. In this one, you have an enzyme which is not working, and therefore you have an accumulation of fat. And if this was an H&E, all this stuff would be washed out, and we'll just look at there's too much fat in this muscle. But in this case, they actually preserved the fat. They probably didn't pass it through the xylene, and then they stained it with something that stains for fat. So you can see all this fat accumulation. That's a lipid metabolic myopathy. In this one, in this metabolic myopathy, there is a defect which results in the overproduction of mitochondria. They're not working well. And in addition, they are various sizes. So if you, can remember what a parking lot looks like in some of the malls, especially, the malls in which women do a lot of shopping, think of the parking lot mitochondria. Okay, I could hear some buzzing. I'm assuming everybody is still hearing me. Maybe somebody hasn't muted their mic. Ooh, somebody said we lost audio. Can everybody hear me? I'm hearing yes, 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 and the buzzing is gone. So I'm assuming we could continue with the last few slides rather than have Isla call everybody again, correct? Okay, good. By the way, Isla, did you learn how to pick up people when they drop without destroying the entire group? Okay, good. That's great. Let's talk about the so-called inflammatory myopathies. And like most of the inflammatory neuropathies, if you don't have a specific, well-recognized pathogen that's causing it, it's probably going to be thrown into the category of autoimmune. So when you hear a disease like dermatomyositis, which is a primary inflammation of muscle and overlying skin, you can think that's probably going to be in the field of autoimmune. Perhaps you'll hear the term polymyositis. It'll be an inflammation of the muscle, no obvious agent. But remember, some organisms can infect muscle, like they can infect anything. And then there's going to be the last thing also with a relatively obscure etiology, which is called an inclusion body myositis. And even though that sounds like kind of a bogus term, it's actually one of the most common forms of myositis in elderly men. So here's a patient with dermatomyositis. You could see that there are some chronic inflammatory changes in the skin. This is not normal skin. But in addition, in the underlying muscles, you can see that there is a lot of inflammation in the muscle too. And look, you can also see something here, which we said was non-specific. It's as non-specific as hypertrophy, atrophy, and that's some vacuolization within the muscle fibers as well. So dermatomyositis is inflammation of both skin and muscle. It's not associated with a specific pathogen etiology. Therefore, it's regarded as generally autoimmune. And if you were to look at these muscles a little bit closer, you'll see that very often the brunt of the inflammation is around blood vessels as well. But in a disease now called polymyositis, you can have inflammation in the muscle, but the inflammation looks like it's around the endomysium. Do you remember with skeletal muscle, like cardiac muscle, you have the epimysium, the perimysium, and then at the very, very lowest fiber level, you have the endomysium. So in polymyositis, we also don't have an etiologic agent, but the inflammation is around the actual membranes surrounding individual fibers, which is the lowest level of mysium, called endomysium. And the last thing, or one of the near to the last, is another obscure disease called inclusion body myositis. Now, if you want to go on Wikipedia and read 20 or 30 theories as to what causes this, all of which conflict each other and waste their time, you can. If you want to believe me that we don't know exactly what causes it, but it has a very, very, very distinctive appearance as having sort of a darkish little inclusion body, perhaps almost looks calcified, usually towards the center of the fiber. Here's one here using one stain. Here's one here using another stain. Here's one here with the regular H&E. Here's another one here in which you could see a more darkening of these little things. These are not nuclei, folks. These are inclusion bodies. We don't know what caused them, but what we do know is that it's the most common acquired myopathy in people over 50. And the quadriceps and the wrist flexors asymmetrically is usually the clinical presentation. Do you remember that people that drink too much can have direct toxic effects to the muscles? If not, you should put that on your list. We mentioned that when we talked about alcohol. You should also know, like for the patients that are on steroids, very often they have sort of a myopathy syndrome where they just lose their muscle strength as well. And that's independent of the fact that people that are on steroids are usually really, really sick and they're not giving their muscles regular exercise. The anti-malarials can also cause a toxic effect to muscles as well. And, you know, from the point of view of medical legal, if you want to look at your package inserts, you could probably make a list of 100 different things that have been known to show toxic effects of muscles. But the most common ones are anti-malarials, steroids, and ethanol. And remember, with thyrotoxicosis, they can get sort of a myopathic picture as well. Okay, the last thing to deal with then, because we dealt with neuropathies and we dealt with myopathies, let's deal with the last category of disease that involves the interface between nerve and muscle. And there is a classical disease of young women usually complaining with muscular eye problems in terms of diplopia, ptosis, perhaps extending to general weakness, called myasthenia gravis. And if you remember, when we're talking about autoimmune diseases, we said that myasthenia gravis is a classical autoimmune disease in which the patients are making antibodies against their own anticholinesterase receptors. And as a result of that, if you wind up giving these patients as a diagnostic test an anticholinesterase, they usually show a quick, dramatic response of all their symptoms. Nobody knows, other than the fact that it is an autoimmune disease and you can identify antibodies. We also know that very often myasthenia gravis is associated with thymomas. And even if there isn't a thymoma, very often they do thymectomies for these patients, and that helps as well. So if you are taking the boards and they tell you that a young woman comes in with double vision or drooping of the eyelids, you know, knee-jerk reflex, you got to think myasthenia. You know, do your anticholinesterase test and see if it makes her do tremendous improvement. Another thing to remember, there is another extremely rare disease, also of the neuromuscular junction, but in this case, it's on the nerve side of the junction rather than in the muscle side or the anticholinesterase receptors. It's called Lambert-Eaton. It's usually associated with a patient that already has a cancer of something else, and that's why it's called paraneoplastic. But whatever it's called, it's very rare. But that pretty much ends our discussion on most of the regular myopathies. But we can't forget the tumors. We've already showed you a picture yesterday of a benign rhabdomyoma, looking sort of like normal skeletal muscle, but not exactly. Then we showed a picture of a malignant proliferation of skeletal muscle called a rhabdomyosarcoma, extremely rare, folks. I have never seen one in my life. I probably will never see one until I die, personally. But remember, the reason why a cell which normally doesn't multiply can form a tumor is that it's not the mature cells that are giving rise to these tumors. It's actually the precursor cells to mature skeletal muscle that proliferates to develop, in the benign case, a rhabdomyoma, in the malignant case, a rhabdomyosarcoma. And whereas a benign rhabdomyoma might remind you a little bit visually of skeletal muscle, this thing is going to look like hell. It's just going to be very pleomorphic, and it's going to look bad. It's going to behave bad, like any regular sarcoma. And guess what, folks? We're done, and we're done a little bit early. And if that means you want to say a few things, you can. I'm going to close down my little PowerPoint over here. If nobody has anything to say, we're going to take the luxury of just quitting a little bit early to make up for all the times I kept you a little bit late. I hear a little bit of buzzing, but I'm assuming people still hear me. I could hear a little bit of buzzing and other people talking, but the most concern is I don't want to think you did not get your money's worth. So I'll ask you the question again. Did everybody hear me pretty well today?
Oh, drat these computers.
No, don't say that, Jim, because the computers behaved themselves today. Looks like everybody heard me well. It looks like you all got your money's worth. I feel good. I feel really good because there's only one more beautiful chapter left. So I also feel really good because I'm having another 5-day weekend. So